Good afternoon, everybody, and welcome to today's webinar on I Raise the Rates, Updates and Changes in 2019. My name is Heather Bennett, and I'm the Executive Director for the New York chapter of ACP. Our facilitator for today's webinar is Dr. Ankita Sagar. Dr. Sagar is the Director of Ambulatory Quality Medicine Service Line and an attending general internal medicine physician at Northwell Health. She is also chair of the New York chapter of ACP's Early Career Physician Committee. Before we begin, I would like to review a couple of guidelines. All participants will be on mute since we have a large audience. And if you have a question, please type it in the dialog box to the right, and Dr. Sagar will answer the questions at the end of the presentation. If we run over the allotted time, we will send the answers to all of your questions via email. We will have the recorded version of today's webinar posted shortly in the Early Career Physician and Recorded Webinars page on the NYACP website, and that is www.nyacp.org. This webinar is accredited for 1.5 CME credit hours and 1.5 MOC points. Following the webinar, we will be sending all participants an email with instructions on how to claim CME credit and MOC points, so you can take care of that on your end. I would now like to introduce Dr. Ankita Sagar.
Okay. Thank you so much, Heather. Welcome, everybody. We're very excited to have you guys join us for the webinar. Before we begin, just wanted to provide some information to you guys also. So the planners and the faculty disclosures for both myself and Heather are listed here, which is none. And then we really do want to acknowledge the generous support of the CDC, as well as funding from Merck Incorporated for ACP Advance, and also making sure you guys are aware that this is part of the I Raise the Rates initiative, which is the American College Physicians thought, and you can access their resources right here on this link, which is acponline.org/AI. Okay. And if you are more interested in some of the quality improvement, practice improvement curriculum that is offered by ACP, it is available for access on this website, which is acponline.org/ACP-advance. And I have no financial disclosures. So let's get started. The learning objectives for today are going to be overview of impact and effectiveness of immunizations, reviewing the updated ACIP recommendations, discerning the barriers to immunization, understanding the source of misinformation regarding vaccines, employing motivational interviewing techniques for patient engagement, initiating team huddles and identifying opportunities. And lastly, we're going to go through a couple of resources that are available for both physicians and patients to further utilize to discuss importance of vaccination. Okay, so let's talk about impact, right? So impact of vaccinations during the past 70 years is pretty significant. So if you can take a look on the first column, we have the various types of vaccines available, right? And the reported cases in the year that is being reported. If you take a look, for example, diphtheria in 2012 went from 5,796 to 0, right? That's a 100% decrease in reported cases. But when we start taking a look at other vaccines that are available but maybe possibly not utilized to its full extent, when we take a look at, for example, hepatitis B, the initially reported cases were closer to 26,000. There is a little bit of underreporting expected in this initial figure, with a decrease which is only 89%. Part of that decrease is being considered because the reported number of cases obviously could be from new cases, but a lot of that are thought to be possibly preventable cases, right, from immunization. So this is why there is an impact. The next I want to share with you is the idea that over the course of the last 9 to 10 years approximately, how have vaccination rates changed? What is the trend over time, right? So when we take a look at it, if you look at the bottom, so this is going to be HPV vaccines. And this is going to be the male vaccination rate, right? So we're increasing our HPV vaccination for males, which is fantastic. And then when you take a look at what is a similar vaccination would be for HPV females, right? So we started back in 2010 once the guidelines were recommended, and we've seen a considerable increase, which is great. Now, the other vaccine that we should definitely take a look at is remember that hepatitis B was one of the vaccines we said has only an 89% decrease in incidence. And when you take a look at the trend, you see that initially about 25%, 26% hepatitis B vaccination, right? And then you see that it has precipitously decreased over time. This is a little bothersome because we can all attest to the fact that we have been seeing newer cases of hepatitis B, which is very concerning. Okay, so really vaccination rates trend over time between 2010 to 2015 have been somewhat steady, if not slightly improving. But really, our goal should be to increase these numbers from below 40% to much higher, closer to what we consider the pneumococcal vaccination rate, which is about 60 to 65%. Okay. Now, the reason I say this is because when we look at specific vaccines alone, so like I mentioned, hepatitis A has about 9% vaccination rate as of 2015, versus hepatitis B has 24.6% average rate in 2015. And then pneumococcal for 19 to 64-year-olds was 23%. Meanwhile, pneumococcal vaccination above 65 is pretty decent. That's what we saw, 63.6%. So really, it is these vaccines that are somewhat concerning, right? So hepatitis A, hepatitis B, influenza, pneumococcal, zoster, and of course HPV vaccines. So we're going to be discussing some of these guidelines as well as resources and how we can improve some of that, right? So this is the overall impact. Now, let's review the ACIP recommendations, right? So that's the Advisory Committee on Immunization Practices, and these are as of June 2019. So usually what the ACIP does is they have a forum, they come together, they give guidelines, and sometimes those guidelines are not really that much changed. But June 2019, we actually have a couple of updates that I want to make sure that we have a chance to discuss. So what are the ones that we're going to discuss? We're going to discuss hepatitis A, HPV, influenza, pneumococcal, as well as zoster vaccination. So let's get started. Let's talk about hepatitis A, right? So what is the impact? So in October of last year, so exactly about a year ago, there were 7,000 hepatitis A outbreak associated cases in the US. Comparatively, if you go back to 2017, there were only 1,500. So you can see there's an exponential increase in hepatitis A outbreak, which is why I think it was important for the ACIP guidelines to recommend change in the approach to hepatitis A. Initially, if you remember, hepatitis A vaccine is recommended for children routinely aged 12 to 23 months, anybody who's wishing to obtain immunity, persons at risk for Hep A infections, that would include travelers to Hep A endemic areas, men who have sex with men, users of injection and non-injection drugs, chronic liver disease patients or clotting factor disorders, as well as persons who anticipate close contact with an international adoptee. This is important because I know for some primary care physicians, myself included, a lot of times we do have to complete clearance forms before a person can become an adoptive parent, and part of that form really should be a discussion around hepatitis A vaccination if the anticipation is the adoptee will be from a country that is higher intermediate endemicity. So what are the updates? So the updates are actually now hepatitis A vaccine is being recommended for all persons with HIV aged more than a year, and also especially persons who are experiencing homelessness. Couple of reasons why: higher risk for hepatitis A infection, but also severe infection associated outcomes have been noted in homeless population. Um, if you do happen to have a patient who is in front of you who is homeless, the recommendation is even one dose of hepatitis A vaccine within 4 weeks for an immunocompetent person can afford 95% antibody creation, which is pretty significant. And the concern about loss to follow up before Hep A vaccine series is completed should not be a deterrent. And ACIP has come down pretty strong on that recommendation to say initiate the dosing, even if we know that we may not be able to complete it. It is still quite important to get even the first dose in for the patient. So Hep A is now being recommended for all those at risk. Okay, so let's move on to human papillomavirus, right? So again, 33,700 HPV-related cancers in the U.S. annually. In contrary to some people's understanding, majority are actually oropharyngeal cancers and not so much cervical cancer alone. So this is a pretty significant burden of disease for the U.S. And given this burden, the impact factor becomes pretty significant, right? So you have 12,900 oropharyngeal cancers among men and women, 10,000 cervical cancer among women, and 6,000 anal cancers responsible for HPV. If you think about how has it changed, so pre-vaccine era, before 2010, 2013 actually, when full adoption of HPV vaccine was initiated in 2013, we went from 11.5% to 1.8% decrease in infection among females. And then for females between 14 and 19 years old. And for older females, 20 to 24 years old, it went from 18.5% to 5.3% decrease, which is pretty significant, right? Now, it is routinely recommended for females through age 26, males through age 21, but the update was really that catch-up vaccines for all persons, regardless of gender, should be recommended through age 26. Okay, so that's important. So regardless of gender, up to age 26, it is being recommended. Beyond age 26 is the shared clinical decision making, especially for individuals between 27 to 45 years who are not adequately vaccinated. What we mean by adequately vaccinated would be they got one of the three series or they got two out of the three. So we do need to catch up on that vaccination schedule. And that is a decision that has a couple of different things to think about, right? So considerations would be risk and cost. Insurers and payers vary on coverage for over 26 years old. So that is something I do encourage patients to find out. And then when we think about economic modeling around vaccination beyond age 26, really the quality adjusted life years has not proven enough of an effect. However, if I have a patient coming in saying my insurance covers it, I want to get vaccinated, I think that it is a pretty reasonable conversation to engage them in. Okay, so influenza. So we're in the flu season now. Congratulations. The impact factor I want to talk about because there's been a lot of different numbers being circulated, and this is directly from the Advisory Committee on Immunization Practice. So over the last 6 influenza seasons, okay, vaccination prevented for each season 1.6 to 6.7 million illnesses, up to 3.1 million outpatient medical visits, up to 87,000 hospital stays, and up to 10,000 respiratory and circulatory deaths. So that's over the trend over the last 6 seasons, right? Now, if we talk about, with the exception of 2 years ago, so 2017 to 2018 season, overall effectiveness of the vaccine for influenza A was about 62%, for influenza B was 50%, and in one season, so 2017 to 2018, season, the vaccine prevented 7.1 million illnesses, which is higher than previous years. 3.7 million outpatient medical visits, which is also higher than the previous years. 109,000 hospital stays nationally, which is much higher than previous years. And lastly, 8,000 respiratory and circulatory deaths. So when we think about the impact of influenza vaccination, the numbers kind of tell you the story. It is extremely important for a lot of folks and everybody. So influenza vaccine at this time is recommended for all persons aged 6 months and older. Those do not have contraindications. We'll go through the contraindications slowly. Now you have the high dose versus a standard dose vaccine. And, superior efficacy against lab-confirmed influenza over the 2 seasons, especially for those over the 65 years for high dose. And thus, it may provide a better protection compared to the standard dose in this specific age group. Contraindications, so obviously allergic reactions to any component, Guillain-Barré syndrome within 6 weeks of influenza vaccination. For those who are going to be vaccinating children or considering live attenuated vaccines, please note that there are some very, very specific contraindications. So for children and adolescents, aspirin or salicylate containing therapy is a contraindication to live attenuated vaccines. For adults, immunocompromised state, or close contact of caregivers of severely immunosuppressed patients, pregnancy, and if there's been any influenza antiviral medication administered within the past 48 hours, a live attenuated vaccine cannot be administered to the patient. So let's talk about timing for influenza vaccine. Ideally by the end of October. However, ACIP has made their recommendations very clear. Continue vaccinating as much as you can until the influenza viruses are circulating and unexpired vaccine is available. So the recommendation is through the entire winter season up to even the tail end of the season. Now, a lot of us face a vaccine supply limitation or shortage, and ACIP has come down pretty clear on the recommendations. So who should be a priority over if you have vaccine limitations? So adults over the age of 50 years old, patients who have a BMI greater than 40, chronic disease burden, specifically pulmonary burden, cardiovascular, excluding isolated hypertension, kidney disease, hepatic, neurologic, hematologic, or metabolic disorders such as diabetes, immunocompromised state, right? Women who are or may become pregnant during the influenza season is going to be somewhat important, as well as residents of nursing homes and long-term care facilities, American Indians, Alaska Natives, and caregivers and contacts for those at risk. And sometimes, we tend to counsel the patients, but maybe not take the next step of counseling the family members or the caregivers of the patients. But it's really important that not just the patient, but even their contacts get influenza vaccination completed. So healthcare personnel, household contacts, especially for children less than 5 years old or adults over the age of 50, household contacts and caregivers of patients with increased complication risk for influenza. Those would all be very, very important. So let's talk about pneumococcal vaccination. Now, if you guys remember, this was the previous schedule, right? So anybody who's over the age of 65 receives one vaccine, 23 or Prevnar 13, and then you administer the other one a year later. Okay, and then if you're less than 65, you would get the 23 first, and then you would administer Prevnar 13 once the patient reached 65 years or older, and then another 23 within 5 years of the previous. Okay, so pretty complicated. I think a lot of folks have a tough time with this one because you have to calculate how many years it's been and whatnot. Um, so currently, all adults over the age of 65 should be receiving a dose of Pneumovax 23, right? So that's PPSV 23. The update to the ACIP guideline is for Prevnar 13, it's a shared decision making for anybody over the age of 65 who does not have an immunocompromising condition. Okay. And the reason this was made was in the ACIP committee transcripts, it seems like there was enough concern that there is this building of herd immunity among our pediatric dosing, right? So you have a lot of pediatric patients getting the Prevnar 13, which may actually suffice in protection for those without immunocompromising conditions, right? And I've listed for you exactly what the child schedule is for Prevnar 13. But remember, this is not for patients with immunocompromising conditions. Their recommendations are still the same for immunocompromising condition patients. The clinical decision making really has to happen between the patient and the physician, because if the patient lives in an area which has very low vaccination rate among pediatric dosing, perhaps it would be appropriate to give them the Prevnar 13. However, if the patient feels, no, I'm good, I choose not to have the Prevnar 13, then you should be feeling comfortable that Pneumovax 23 alone should be suffice as long as they're not immunocompromised. So, zoster vaccination. We have two options. So you have zoster vaccine live, and you have a recombinant zoster vaccine, which was approved in 2017. The update really has been that the recombinant, also known as Shingrix, is being approved and recommended for use in immunocompetent patients over the age of 50. And the reason for it is because evidence supporting RZV is pretty significant, right? So in patients between the ages of 50 and 59 years, they have found prevention for herpes zosters in 96.6% of the patients with a pretty significant confidence interval, which somewhat increases if you're above the age of 60 and slightly lower if you're over the age of 70, but really overall over 90% prevention of herpes zoster is pretty significant. Now, if you're like me and you want to know how many patients you need to vaccinate to prevent one case of Shingrix, of zoster, for Shingrix, to prevent one case of herpes zoster, you need to vaccinate approximately 11 to 17 patients, which is a small amount, relatively, versus to prevent one case of post-herpetic neuralgia, about 70 to 80 patients. So it's pretty significant. Now, these are based on clinical trials, phase 3 trial. Okay, these are not necessarily going to be direct comparison trials between zoster vaccine live or recombinant. However, this is the data that is available to us right now. And this is the data that's cited by the ACIP. So looking at the recombinant vaccine, right? So it's 2 doses, half ml each, and it's administered intramuscularly 2 to 6 months apart. Okay. Timing for it, if the patient was previously vaccinated with the live vaccine, as long as it's more than 2 months after the live vaccine, it is considered safe. There's no data or theoretical concerns that RZV would be less safe or less effective. So more than 2 months apart, you should be okay. For patients with a history of herpes zosters, which a lot of my patients come in saying, oh, I had the shingles already. One of the key things is we all understand that zoster can recur, and adults with a history of herpes zoster should actually receive the recombinant vaccine to avoid repeat occurrence. For immunocompromised patients, in persons taking low dose immunosuppressive therapy, so think less than 20 milligrams a day of prednisone or inhaled or topical steroids with equivalents, um, or people anticipating immunosuppression or have completely recovered, ACIP does recommend recombinant zoster vaccine. For immunocompromised persons, so high dose, moderate dose immunosuppressive therapy, were excluded from efficacy studies. So ACIP has not made any recommendation. I think that post-marketing analysis still needs to come, and hopefully in the coming year or so, maybe we will have more clarity on that recommendation. Last question is whether we should be screening immunity before we give the vaccine. So screening for a history of varicella, whether it's verbally or laboratory serologies before vaccination, is not recommended because even if the patient does have immunity shown, the concern is that the patient could still have a recurrence of zoster. Okay, so we've reviewed our ACIP recommendations. So let's talk a little bit about barriers to immunization, right? Like what is causing a significant amount of concern around providing immunizations or patients accepting immunizations from physicians. So remember when we had talked about the impact, right? So there's clearly certain immunizations that have a pretty significant impact and other ones that are not having a great impact. So economic impact of under-vaccination is about 14.1 million cases of vaccine preventable diseases in 2015, which are attributed to unvaccinated adults. So 14.1 million cases. Total economic burden will be about $9 billion. Direct cost, loss of productivity, all of those, right? And this is a study that was done and published in 2016 in Health Affairs. So, from both economic but also public health concern, there's pretty significant concern. And when we think about it, the question becomes, what are the barriers to immunization, right? And there's usually three main categories, right? So there's the patient engagement portion of it. There's the missed opportunity for immunization, right? And then lastly, misinformation, meaning patient community information is incorrect or inaccurate. So we're going to go through some of these things, right? And the first thing we're going to go through actually is to talk about misinformation. Because I think this is a very, very common occurrence, I think most internal medicine docs can speak to the fact that a lot of times patients will come in and say, oh, no, I heard things are, if I get the vaccine, I'm going to get sicker, I'm going to get autism, and the whole gamut, right? So let's explore the source of this autism link, because I think it's important for us to recognize it. And first and foremost, basically in 1998, Lancet published a paper by Dr. Andrew Wakefield in which it was a dramatic study which linked autism and vaccines. Okay. However, when you look at this study with a constructive view, you realize that the statistics were not matching up. There was no control group. A lot of it relied on back memory, right? And very vague conclusions were made. However, it was published in 1998 in Lancet. Well, what happened after that? So in 1999, a newer study was published, 500 children, medium, moderate size study, right? No connection between autism and vaccination. And then 2001, a newer study, 10,000 children, still no connection. 2002, another study in Denmark, similar population as the initial study, 537,000 children, no connection was found. And then immediately after that, there was another study published from Finland, which had 535,000, again, no connection found. In 2004, finally, Lancet actually released a statement refuting the original findings that were published back in 1998. However, questions still continued to circulate, right? So there was a meta-analysis in 2005, 31 studies, 10 million children, no connection between vaccination and autism. And in 2012, another study, 27 cohort studies, 17 case controls, multiple series style trials, as well as two ecological studies were done, all in one meta analysis. 14.7 million children, no connection found, right? And Lancet basically said that they had conducted this investigation, children without obtaining ethical clearances, chose data, was falsified facts. However, I think the damage was done, right? Because now a lot of folks will claim that initial 1998 study as a truth. And I think that the follow up studies are really, really important for physicians to be aware of because you can actually say we've looked at 14.7 million children over the course of the last 10, 15 years and have found no association between vaccination and autism. So please note that what your patients are coming in with is probably going to be this misinformation that's subject to this one Lancet publication back in 1998. Okay. So now that we understand what is the source of the link between vaccination and misinformation, let's talk about motivational interviewing because when the patient is coming to you and saying, I'm not interested in this vaccination, I'm not sure how it's going to make me feel, I've heard bad things about it, the question really becomes is this all they're thinking or is there something else going on? So the American Journal of Medicine published actually a great article, Barriers to Adult Immunization, a couple of years ago. And basically, they interviewed patients and said, hey, we noticed you didn't get your influenza shot. Why? And then also patients who did not get their pneumococcal vaccination, why? And what they found the most common responses were, for influenza, I'm healthy, I don't need it. Oh, I heard there's a shortage. Others need it more, I don't. And I heard there might be side effects. And then the fourth most common was the doctor hasn't told me I needed it. Right? For pneumococcal, similar. Healthy, I don't need it. Doctor hasn't told me and may have side effects. So you see, what we think is only misinformation is not the only concern. Patient engagement is also important, right? Because a lot of times patients are waiting for their physician to inform them about vaccination or to inform them about side effects and the likelihood. And so the question becomes, is there a way to impact these reasons for under-vaccination? So that's when motivational interviewing comes into play. And this set of series were slides I actually adopted from I Raise the Rates initial slide set. So if you look at it, motivational interviewing, which is MI, in one study actually enrolled specialists who were trained in motivational interviewing, and they found that patient engagement in that health management program quadrupled. So before the motivational interviewing specialist came in was a baseline. After motivational interviewing, quadrupled. And why, right? So motivational interviewing is built on a couple of core concepts, which is expressing empathy to build rapport, develop discrepancy, elicit the pros and cons, try to understand how the patient is looking at it. Roll with the resistance, the idea that the patient does have autonomy. And perhaps the way they're thinking about it, you want to keep pulling at those strings a little bit more. And supporting self efficacy. Communicating with the patient that they are capable of change. And if they choose to do so, they will succeed on it. So, really providing a more coaching and supportive role rather than a paternalistic role. Right? So, how does that look? So, the spirit of motivational interviewing is collaborative, evocation, as well as autonomy. So let's talk about collaboration, right? The idea that is very interesting in motivational interviewing is that the patient is actually the expert on how the patient is feeling and what they're thinking. But the physician creates an atmosphere that is conducive to the discussion rather than coercive, right? So going into the conversation saying, listen, you and I are a team, and I'm just here to create the environment and atmosphere in which you feel most comfortable, versus thinking about it as that the patient is not understanding the situation, and that the physician has to impose a reality of the situation. Um, the second part is, evocation, meaning motivation from within the patient. So motivating the patient to access the resources from within the patient versus educating the patient. So what does evocation look like? The idea that, hey, you are a patient and that you have the ability to access resources in this clinic or outside the community, and I'm just going to help you do that. Versus educating by the idea that a physician or a clinician has to enlighten the patient to all the necessary changes that are needed. And the education part can backfire for two reasons. One, it can be very overwhelming for the patient to realize how many changes they have to make at once. And two, some patients may feel a little uneasy in expressing their own thoughts and feelings, which ties really well into autonomy, right? That the patient has a right and capacity for self-direction, that the physician respects this and affirms this and will continuously ask, are you okay with this? What do you think about this? How do you feel about it? Rather than saying what the patient must do or should feel, because that is a more authoritative approach, which may not work very well for motivational interviewing and really building that patient engagement. Um, so, how do you actually do it? So there's a mnemonic called ORS, meaning open questions. So questions that cannot be answered one word, right? If we go back to affirmations, so statements that establish a respectful, collaborative relationship, acknowledging commitment from the patient to self-care, reflecting on what the patient has said, so actually acknowledging and saying back to them, right? And then lastly, summarizing. So one way of thinking about it would be, let's say a patient comes to you and says, I don't want the flu shot because my mom got the flu shot and then she got sick. So I would approach it saying, okay, open questions. Tell me more about how you felt when your mom got the flu shot and then got sick. And then the patient may say, I felt very scared. I don't want it because maybe I'll get sick. And then affirmation, right? So saying, I understand this can be very scary, and your concern is that you don't want to get sick like your mom did. And then reflecting on it and saying, this is a tough place to be because part of it is that you want to take care of yourself by getting the flu shot, but part of it is you don't want to get sick. And then summarizing and basically saying, you have two options and you can think about it, but when we look at the data, perhaps it will help you understand that the effect of the flu shot later on may be very helpful to you. But leave it to the patient to decide, right? So that's part of the motivational interviewing. One last thing about motivational interviewing is that if you go to the website at the bottom here for I Raise the Rates webinars on ACP, they actually have a couple of great videos for you to access on the conversations for motivational interviewing. Okay. So, team huddles, right? And identifying opportunities to vaccinate. So like we said, there's three concepts, three frameworks for missing vaccinations. So misinformation, patient engagement, and missed opportunity. And really the missed opportunity, one of the resources we want to share with you is the idea of a team huddle. And the team huddle basically is a concept that we've borrowed. And what it is basically a short daily meeting with a teamlet. So the physician or clinician, a medical assistant, and if there's other support staff, whether it's an RN or a front desk person. And the concept is that it provides an opportunity for members to come together and anticipate the agenda for the day for the patient's visit. It usually lasts less than 10 minutes. That's key. So we're not going into very, very deep depths of why the patient is coming in, but really kind of summarizing to say, what are the things that we must address today and how can we plan for it? Now, is it supported by clinical evidence? Absolutely. So a lot of professional organizations have voiced significant support for team huddles because it works, right? So the AHRQ has a very large campaign around team huddles. AMA Steps Forward also has one that they have paired with SGIM to circulate team huddle checklists and packages. Institute for Healthcare Improvement, or IHI, is a very large proponent of interprofessional, interdisciplinary team huddles. And the UCSF Center for Excellence in Primary Care also has a packet online that you can access for team huddles to make them a little easier. The question is, why is a team huddle helpful, right? The first thing is it builds a culture for the team. Why? Because it's a moment in the day for you to check in with your team. And it's automatically built in. It is the default. And it allows everybody to kind of take the temperature of the room or the team to understand what is going on, right? Enhances communication between the core team members. Because if it's the same teamlet every day or every other day, what ends up happening is folks tend to anticipate the needs of their team members quicker. It prepares the staff for patient visits, allowing anticipation of patient needs. So if it's your front desk person is involved in the teamlet, they can anticipate saying, okay, you may need an extra few minutes with this patient because they seem very upset today. Which also then identifies spots for additional patient access, right? And lastly, you can address and review potential staffing issues in the beginning of your clinical day rather than while you're trying to get through your clinical day. And this is really important because when we are delegating patient care, it is going to be very essential for the team member to be able to understand who is available and who is not. So, what topics should you address in the huddle? Now, this is just a list of a few. You don't have to address every single one of these, but these are recommended ways to use the huddle. So, print out the scheduled patients for the day, review them one by one. Identify the members of your team that are going to be involved with the patient care. So, sometimes I will say, okay, I really need the front desk to schedule a follow up likely in 3 months, 6 months, however much, right? Or, okay, this patient is coming in for a medical clearance. We will need an EKG for this patient for this reason. Or if you need any other assistance, like point of care testing, your medical assistant can be well aware of what are the needs during the visit. Identifying and prioritizing care gaps for primary care folks and a lot of our other specialists on the webinar, this is going to be really important because our team members can actually help us identify care gaps so that as the clinician in the team, you don't feel like you're the only one who has to sit with the care gap. So a lot of times in our practice, for example, we will have our medical office assistants actually do a checklist in which did the patient have a mammogram? Did they have vaccinations up to date or colonoscopies and colon cancer screening that's up to date? So this is a big part of our team huddle. And then we also identify candidates for nursing education or diabetic education or also extended care team involvement. So whether it is social workers, case managers, behavioral health, community-based organizations, a lot of the folks I know around the area have been doing work in social determinants of health. So all of those referrals that need to be made or considered can be actually done during that team huddle. We talked briefly about opportunities for additional patient access. Sometimes patients may not cancel their appointments, or sometimes patients may need to be brought in for an acute care. This is the time to identify those folks. And also to highlight patients who are not coming in for their appointments, right? Because maybe during the team huddle, a team member can get assigned to say, can you call them, make sure they come in today? Or can we find out whether they're coming in today? So that does two things. One, it relays delegation of task, and two, it relays to the patient that it is important for them to come in and that you are expecting them to come in. And then the last thing is ensuring medical records from outside facilities, especially for post-discharge visits, radiology, tests that need to be followed up, lab testing, pathology reports. We all know there's so many of these things that it is actually quite important for us to go through. But a team huddle is a good time to delegate those tasks to other team members who can potentially help you with it. Now, some people ask, does it have to be daily? My recommendation is yes, but if your schedule cannot accommodate it, then maybe every 2 days. You could also do it the night before or the evening before at the end of the day. It doesn't have to be first thing in the morning, but I think implementing the team huddle is very, very helpful, both for you as a clinician, but also your team members, because then they are in the know and they understand and they communicate their needs as well as yours much better. Okay, so resources, right? So there's a couple of resources that I want to highlight. So first, we're going to go through the resources for patients. So the CDC actually has vaccination information sheets, right? We all know those, which are available on cdc.gov. But the CDC also created a separate independent website called immunize.org, which goes into discussions about immunizations, really tries to give patient level information about a lot of the misinformation that's out there, side effects that can be expected, cost of vaccinations, and lastly, the appropriate scheduling for vaccinations. I think this website is actually phenomenal because I have referred to it more than once when patients come in, especially those who are very concerned about inorganic material in vaccinations and substrates. And the immunize.org actually has a list of all the ingredients of vaccines and why they are in the vaccine, but more importantly, where else can they be found in our natural environment. So I think it's very helpful. Families Fighting Flu, so this is particularly for influenza campaigns, which is a family perspective from various families who have either lost loved ones or have suffered the consequences of severe influenza. Again, a great patient education website. Immunization Action Coalition, which is at vaccineinformation.org, different than the CDC, again, coming it from a very patient-centered manner. And WHO, which has been having their own campaign to improve vaccination rates around the globe, has a great newsroom kit which details myths and facts around vaccines. So sometimes I do refer patients to that as well. But I think it's really helpful for even physicians to read because you will then be able to give the appropriate information when patients come in with these myths that they're hearing from whether it's culture, pop culture, or media, and such, so on and so forth. Okay. Resources for physicians. So, like I said, ACP, I Raise the Rates, has webinars specific for multitude of topics, anywhere from vaccination guidelines to cost of care to patient engagement to team huddles, checklists. So they have more than a few webinars available for you to utilize. And I encourage you guys to share those and also utilize them. AHRQ has a specific team huddles bundle that you can download, multiple different checklists, multiple frameworks for creating a teamlet, and really doing the team huddles. And then we also have the updates to ACIP recommendations, which is also available at immunize.org, which has two sides, a physician-facing as well as the patient-facing side. And then the actual ACIP guidelines and recommendation, which are available at cdc.gov. Okay, so that brings us to the conclusion of this portion of the webinar, but I do want to go through some of the questions because I want to make sure that we have a chance to go through them. So let's go through them. So question one, so let's say the ACIP from CDC has a recommendation that physicians consider what patient factor as an indicator for Hep A vaccine. So I'll let you guys take a minute to look through that. Okay, so the options are age over 60, homelessness, homebound, tobacco smoker, right? So those are the questions. All right. Question two. So the ACIP recommends recombinant zoster vaccine, right? But a recommendation that physicians consider the following at the time of recommendation for the recombinant vaccine. So would you say 2 dosing, administered 2 to 6 months apart? Administered to adults with a history of herpes zoster? Screening for a history of varicella before vaccination for herpes zoster is not recommended. D, all of the above, or E, none of the above. Okay. And then the third question, which is, again, ACIP guidelines recommend that physicians consider HPV vaccination for which patient? Females over the age of 45, males through the age of 65, only persons known to have HPV disease, or all persons through age 26. Okay, so let's go through that. So MOC question one, right? So this is ACIP recommendation. What patient factor as an indicator for Hep A vaccination? So age over 60, homelessness, homebound, or smoker. And the right answer is homelessness, right? So if you remember, all persons with HIV over the age of 1 year are recommended for Hep A vaccination. All persons going to an endemic area are recommended to get a hepatitis A vaccination. But very important for patients who are experiencing homelessness or at high risk for homelessness should be given hepatitis A vaccine, even if it's just 1 dose, because within 4 weeks, 95% antibody development for immunocompetent patients. So it's really very important. So consideration around loss of follow-up should really be lower in reasons not to vaccine, but really we should be vaccinating patients at risk for homelessness. Okay. So MOC question 2 is going to be about ACIP recommendation. What should physicians or clinicians consider at time of recommendation for recombinant zoster vaccine? Your options were 2 doses intramuscularly 2 to 6 months apart. Adults with a history of herpes zoster should receive RZV, and screening for a history of varicella is not recommended prior to vaccination. And the answer is all of the above, because 2 dosing, right, 0.5 ml each, administered intramuscularly 2 to 6 months apart. Patients with a history of their herpes zoster should still be recommended to get the recombinant vaccine. And screening for a history of varicella is not recommended in any form, whether it's verbally or serology. Okay. And lastly, so ACIP recommendation for a physician to consider HPV vaccine for which patient over the age of 45 rather, for females. For males through the age of 65, only persons known to have HPV disease, or all persons through age 26. And the answer is all persons through age 26. So if you remember, it's recommended for catch-up vaccine for all persons, so especially males who were not offered vaccine past age 21 should be offered vaccination through age 26. And beyond age 26, it's a shared clinical decision making. Again, cost is a factor because not all insurers and payers will cover beyond age 26 at this time, but it can certainly be something to consider. Okay. Okay, and that brings us to questions, comments, and feedback.
Okay, Dr. Segar, this is Heather. I have 2 questions that I've received so far. Sorry for the background noise. There's construction. Apologize for that. The first is relates to the shingles vaccine. And the question is, how does a physician decide between the early 2-month versus 6-month second dose?
All right, so that's a great question. There's no specific guidelines on when to give 2 to 6 months. I think certainly what we're recommending patients is do not get it before 2 months. So I actually have them mark their calendar to get it about 3 to 4 months after. One of the things I tell patients is not to wait till 6 months because there has been a shortage of the recombinant vaccination in our local area. So when they call their pharmacies to get it 6 months later, they may actually end up waiting an extra 2 months. So I usually tell them 3 to 4 months, call them, make sure they have the vaccine, but they can wait up to 6 months.
Okay, thank you very much. The other question I have is, can we assume that all commercial insurers cover office vaccinations?
Oh, that's a great question. No, I don't think you should assume that. So we recently found out, so for example, Shingrix vaccine, we found out that for our local area, they were not covering it if we administered it to the patient. So the patient would be given a specific bill for both the vaccine as well as clinician administration of the vaccine, which was not being reimbursed by insurers. But if the patients were able to get the vaccine at the pharmacy, they would only have to pay for the vaccination and not the clinician fee. So what I tell patients is, prior to having vaccinations, it's important to know what is covered. Generally, influenza and pneumococcal vaccines are covered by insurers. Those are the only 2 I would feel pretty confident in saying that they should be covered. But my recommendation is to always check.
Okay, thank you. Would anybody else like to submit a last minute question? Okay, I'll turn it over to Karen Labello in the office.
Great, thanks, Heather. And Kita, thank you very much for doing the wonderful presentation today. And we just got another question in. Is the lack of coverage for Shingrix in the office only for Medicare?
So I know that Medicare is not covering, but I think so. For example, in our local area, some United Healthcare plans are covering in-office administration, but when it comes to non-United Healthcare plans, a lot of them are not covering. So to be honest with you, I think it's really difficult to put the onus on the clinician to figure out all those details of the plans. What I usually tell patients is, when we identify in our team huddle that a patient might need Shingrix, we have them, as soon as they come in, call their insurance company to find out if Shingrix will be covered or not.
Okay, great. Thank you. Well, that concludes our webinar today. I just want to remind our participants that within the next day or 2, you'll be receiving an email from myself with ACP CME accreditation information and the MOC links for you guys to submit for points. This webinar will be recorded and posted on our website on the recorded webinars page and also on the early career physicians page. And we hope you'll join us on December 11th. We have a webinar on vaping that Dr. Cigar will be presenting along with Dr. Kanjir. So if you have any additional information or additional comments, please feel free to respond to the email I send out. Dr. Cigar, any last minute comments you want to say?
I think that the ACIP website is really important for updates and guidelines. And the cost issue is a serious one, and I'm very cognizant of that. And I think we are trying to work on having it be accommodated, but otherwise, refer to the website. You have some great resources out there.
Great, thanks again. Once again, I'd like to thank all attendees who participated today and have a wonderful Thanksgiving holiday. Happy Thanksgiving, Dr. Cigar.
Thank you.
Bye-bye.
You too. Bye.